Hey girlfriend, this is Jan James. Welcome to the Hope After Breast Cancer podcast, where women who have endured breast cancer learn to have fulfillment over frustration, clarity over confusion, and faith over fear. We tackle the issues that many of our sisters face after a breast cancer diagnosis, from brain fog to fear of recurrence, from menopause to sex after breast cancer. This is the place to learn how to have hope after breast cancer. So strap yourself in. Welcome to the Hope After Breast Cancer podcast. Hi everyone, it's Jan James from the Hope After Breast Cancer podcast. And oh my gosh, I am so delighted to introduce you to my new friend and our contributing expert, Dr. Rachel Rubin, who is a board certified urologist and, wait for it, sexual medicine specialist. Yay, the crowd goes wild. Hi, Rachel, so glad to have you here today.
Thank you so much for having me. When you came into my direct messages, it was like a call from heaven of a giant population of women that I want, that need help and that need good information. And just bless you for bringing people together and making people understand that their quality of lives are so damn important.
I know that is something I want to get into with you because you have a very specific, it is unique, but I think it needs to be a more prominent point of view in our community because I think we're lacking some things, but we'll get into that in a minute. Here's what I want to know. You know, I am always so grateful for people that really went into the healthcare industry as their career, but okay, and same to you. Thank you so much for your service. But urology, what? How did that all happen? I mean, where did that passion come from? So I'm just curious about your story.
The little girl who always dreamed of being a penis doctor, right? It was
right,
just
exactly.
come true. It doesn't quite work out that way, right? It's a series of funny events, of funny mishaps. And so, you know, really, Jan, it was finding through medical school what I was passionate about, what I was interested in. I went into medical school not thinking I was smart enough to be a doctor, and then passing every exam in college and just saying, okay, what's next? And never thinking I could do it or was smart enough, had imposter syndrome, but then every step of the way just found something I was interested in. So it started with kind of interest in neuroscience and brain and behavior. And then when I got to medical school, kind of like, oh, women's health sounds really interesting, but do I have to deliver babies? Because I don't want to deliver babies as a living. And so I found urology as this incredible space where you could be a surgeon, you could take care of patients long-term, and you could talk about issues that were made people really uncomfortable, which I was always good at, not because I was good at it, but because I wasn't afraid of it and I was interested in it. I'm a very nosy person where I really do want to know your business, and I do genuinely care, which I found out later is not like a trait everybody has. And so the more I saw people ahead of me or above me sort of not having conversations that I wanted to have, I sort of ran to the fire instead of ran away from the fire. And so I found urology to be this incredible space where you could talk about private parts, where you could talk about sexual health, and that you could see all genders. And that I think the idea that all women's health must be gynecology is like the misogynistic issue of the century, right? Like the idea that only one, this is why women's health is so poorly studied and so poorly researched and funded, is because we just say, oh, all of women's health goes to gynecology and then men's health gets all the other specialties. Like, what is that about? And so I really try to change the urology space of urologists are capable and board certified to take care of all genders. We just are worse at it for one gender, and we have to change that. And so I do a lot of, I'm a bit of a disruptor. Like I poke at the bear and I kind of ask questions, and people don't like that very much, right? When you start questioning, like, well, why do we do it this way? And why aren't we as good at taking care of women? And why don't we know that answer? Why is there no research for this question? I don't accept the answer of like, that's just the way we've always done it. And so that's kind of what makes me unique. But urology is an incredible field that really does take care of all genders and does deal with sexual health issues from a quality of life approach that I think not all gynecologists are trained well in.
Well, and I think just to bridge that gap, you're saying gynecologists, I would come at it from the oncology field. Because I think all of our women, almost to a person, would agree that there's a huge gap in the oncology model especially for post-active treatment. It's the Grand Canyon of nothingness, which is why we exist, right? Because I also did not feel like there's no answers to that was the right answer. So yeah, we went to find the answers.
And it's frustrating, right? When you're this oncologist, you just are like, well, I cured your cancer, or you're in remission and you've got all these years. Give me a high five. Don't complain that your libido's low. Don't complain that you're having pain with intercourse. Like, I gave you life, lady. Get out of my office.
Right.
And that's unacceptable. And so I think the problem is we have started to get much better at our treatments. Thank God, right? Thank God the technology, the research is really advancing, and we're getting people all these extra years. But we are not focusing on the life in those years. And that is the place where I think, again, expecting your oncologist to do it all is unfair, just like expecting your gynecologist to do it all is unfair. But we must invest in education, and we must invest in training people who do care about quality of life issues. And it cannot just be from the psychosocial field, because it is not all psychosocial. Much of this is very biological and hormonal and tissue level and infections and pain, and libido is not all have a date night and drink a glass of wine, which can increase your risk of recurrence, right? It is actually a lot of dopamine. It's a lot of norepinephrine. It's a lot of estrogen. It's a lot of testosterone. And we must understand that from the oncologic perspective. And so there's a lot we don't know, of course, but that's a challenge of, okay, let's figure it out and let's rock and roll.
Right. So you've spent many years as a urology surgeon, but you recently made a change in your career path. So let's talk about that. Like, what informed that decision? What made you move out of, I don't know what to call it, the system? You're out on your own and focusing on sexual medicine, right?
Yeah, I've actually always focused on sexual medicine since my training. So I trained as a urologist. It's a 5-year surgical training. I then did a fellowship in sexual medicine, and then was out in practice for about 4 years, but just started my own practice a few months ago. And really it was my focus of saying, I want to spend time with people, that I can't see 50 patients a day and I can't do good sexual medicine in quick 10-minute visits, that people need time. And if I'm going to figure out your quality of life and help you enhance your quality of life, well, I have to get to know you in order to do that. And if I don't know you and know what your goals are, well, then how can I be an effective sort of a provider and practitioner? And so that's really what it came to. And so medicine, as all of the people listening to this know, is as I like to say, a dumpster fire of brokenness, right? It is very broken in every aspect of it. And I can't fix it by myself. Like I can't fix it. And so I have, in order to spare my sanity and to give my patients the care that I want them to have, I have my own tiny little office in my tiny little world, and I just keep it really small. And at some point, do I grow bigger and expand? Maybe, but it feels really safe and good to be in my protected space. That's my time. That's my patient visits. And I get to decide with the patients how much time we spend and what we do and what the course of treatment that makes sense. And no one else gets to tell us what to do.
Yeah, your perspective when we first met about the quality of life issue was really like it breathed life into me again, because I was like, oh my gosh, that it's something that we don't discuss. So from the urology standpoint, why is quality of life so important when it comes to urological issues? And what the heck happened to the breast cancer community that we don't even talk about that?
So I think this comes from a very misogynistic place. And I want to be very clear about that, right? If you look at urologists, what do we take care of? We take care of enlarged prostates. We take care of erectile dysfunction. Certainly we do a lot of cancer, kidney cancer, bladder cancer, prostate cancer, urethral cancers. We do kidney stones, things like that. But we do a ton of quality of life medicine in urology. So if you're a man that's peeing all night long, we have 1,000 procedures to offer you of every cutting edge technology to make you urinate better. If you are upset by your erections? Well, I've got all sorts of things to inject or implant or give you pills. We have incredible technologies to help with erectile function, which is a quality of life issue for most people. When it comes to testosterone and giving men this vitality, right? There's 26 plus, even more, it's a lot more now, types of testosterone that I can give a man, which help with libido and erections and energies, all quality of life stuff, right? Which is wonderful. I treat men about 50% of my patient case, and I love doing men's health because men deserve a quality of life. But it is a very normal conversation for a urologist to have with a guy that says, oh, sir, you don't want prostate cancer surgery because you want to keep your ejaculation going? Totally get it. That's awesome. High five, quality of life. You do you. This is called shared decision making. I'll give you my advice. Here's the type of cancer you have. Here's what I recommend. But like, you do you. Like, if you want to, cut the years we think you're going to have in your life so that you can keep on ejaculating because that's important to you, that is completely normal and an okay decision to have. That is an unheard of conversation in the female world. It doesn't happen, right? We fear monger. We make you afraid. We say we have to throw everything at you to cut down your risk by the most possible way. And we don't care what kind of quality of life we have to destroy on the way. And we do not do a good job, as it's getting better, but we don't do as much of a good job of risk assessment of, ma'am, do you like being able to wear pants? Do you like wiping yourself? Do you like being able to sit without pain? Do you like not waking up all night urinating? Do you like not having recurrent urinary tract infections with resistant antibiotics that are going to kill you? We don't have those conversations, very siloed, of making women choose between life and quality of life. And it's an unfair decision, nor is it one that's based in data, right? There is no data to show that some of these things that we put fear into women of doing actually have repercussions. So we're actually hurting people. 50% of women go off their tamoxifen and anastrozole because of side effects, but where's the research in diminishing side effects? Where is that research? Because that's the research that I need to see so that I can show patients, look at this trial that was done that the NIH funded that showed no increased risk of recurrence, no increased risk of progression. That's what we need to be seeing more of. I know that was long-winded, but
that is exactly what I wanted to hear, because that's kind of the path that I was on. In addition to loving this season of my life in helping our women, my education is skyrocketing, right? And so I was one of those patients that had the fear of God put into me about everything estrogen. And I think you were the sixth of our experts that said to me, no, you should absolutely get on vaginal estrogen. There's no, how did you put it? There's no data.
There's no data to show any harm of vaginal estrogen. And the oncologists who understand this space agree. And so that is where, do we need more data? Absolutely, we need more data, right? It's insane that in 2022, I'm having to beg for basic data, but there is no data to show harm. And there's so much data to show benefit. Now, there is a lot of controversy in whole body estrogen and whole body hormones. And that's a whole other conversation. And there is a lot of politics and drama and lack of research in that arena. It's important, and I would like to see the data go there. But when it comes to local vaginal hormones to prevent urinary tract infections, to heal the local vaginal tissue, to make the microbiome of the vagina and the urethra and the bladder healthy so that it can fight infection, so that you can have sex if you want it, so that you can not get UTI, so that you can not urinate all night long and risk falling in the middle of the night. That is safe. And that is safe for every woman, regardless of family history of breast cancer. We think, and we honestly believe, current breast cancer survivors, even ones that may have advanced disease. Now, is the data totally clear 100%? If you're on anastrozole and you add a little bit of local estrogen, yes, there is this gray zone of data-free information where we're not sure, but we don't have slam dunk data to show harm. And we have very localized, tiny doses of local estrogen that really show benefit benefit and don't give your body any systemic absorption. And so we have colleagues at Memorial Sloan Kettering who are researching this, and we have colleagues within sort of the ASCO cancer world who do come out there. There are many breast cancer advocates out there who are very, very cautious and conservative, and even they get out there and say, Rubin, you're right, you can use vaginal estrogen. It's safe to do so. And I see in my clinic the benefits and the miracles that can happen for women, where it's no question, right? It's no question how much better we can improve quality of life and how much more we can keep them on their chemo prevention agents and their therapies. Wow. So like, can't we have it all? Like, can't we have it all? Why do we have to make women choose all the time? Like, let's let them have it all. And then there's some non-hormonal options that the research that's coming out is so exciting of, can we boost dopamine in your brain so that we can get your libido back a little bit? There's a great trial just done at Memorial, a pilot study at Memorial Sloan Kettering looking at agents for low libido. There's 2 FDA approved medicines for low libido. And this was a study on one of them that did show improvement in libido and satisfying sexual events. And the words from the patients in this study were just incredible of like, it's amazing.
Well, that's so good to hear that there are advancements that are happening. That's so important. Well, I can't even, I will share publicly. When I got off my introductory call with you, I walked into my husband and said, there is my life before Rachel Rubin and there is my life after Rachel Rubin. I'm not sure what just happened, but
you gotta be careful. You're gonna make my ego get even bigger than it already is.
Get over yourself, because I'm very fickle about who's my favorite, so everybody knows that. But anyway, no, I just, your passion for research, I think, is something that we didn't have in our larger contributing expert group. And you're just like a perfect puzzle piece that just flopped in my lap. And flopped is probably not a word I should use to a urologist.
Not to a urologist. We like to fix
flopping.
But we like puns. We very much like puns. In fact, I just bought this for my office. It's a pen that has penises on it, but it's also a light that shines the picture of a penis. I can't.
Excellent. Yeah. Well, we're on podcast, so they can't see that.
They can't, but yeah. So it's a vision. Sorry, it's not
okay.
A video.
All right.
All right. But so that's very kind of you to say. And I think research, we must demand high quality research. I think that is the thing that sets us apart from the snake oil salesmen who want to sell you a bunch of garbage, right? Every supplement in the world that they claim is going to not harm you, they don't have data. I'm not saying don't use it if you feel comfortable, but no one's regulating that industry. There is no data. So people love to sell you things. They love to tell you that this natural thing is going to fix all your problems, but we must demand higher level data from the world. And I think it's easy for these companies to take advantage of women, and for women to allow themselves to believe in the snake oil. And so we must demand better research. And this group, it's honestly patient advocates that I believe change the world. I don't think it comes from medicine. I think it will come from all of you yelling and screaming and demanding it.
And who, to our oncologists, or how do we go about that?
So we form, we form advocacy groups, and we march on Congress, and we march in the Senate, and we demand the FDA change the box warning of vaginal estrogen, and we demand more studies, and we fund studies, and we raise money for studies, and we get angry. If you have, there's an amazing advocacy campaign going on in Great Britain right now for hormone therapy in menopause. And because a few journalists and celebrities have kind of gotten together and banded together and organized, it is a movement to the point where the British government had to announce that one of their parliamentary people was the czar of hormone therapy, because there were shortages of hormone therapy, and they had to get someone within parliament to be the czar to figure out why it was going on, because so many people wanted it, and now there were shortages because of that movement. And so it is within, if the breast cancer community, which there is money, there is incredible advocacy. What the breast cancer world has done is absolutely incredible. Now, if they can now move it into we demand quality of life. You're keeping us alive now we want to live. And so we must demand those studies, and we must not have to choose between living and life. And that it shouldn't be that choice. The men don't have to make that choice. And so it will take the voices of those advocacy organizations to do that. And you've got the numbers, my friend. All we have to do is organize and figure out what are the needs, what do we need, and demand it.
Well, you are, honestly, you are breathing life into the efforts that we've made, and just am so grateful. And you're connecting me with so many other people that are like-minded. So for our community, you can see many, many more people as fired up as Rachel in the future, because I don't know, life before Rachel, life after Rachel, and I'm excited about it. So that's awesome. Well, thank you for taking the time to let our women know who you are, what you're about, what they can expect. And guess what? You gave them hope, and that's what Hope After Breast Cancer is all about. So thank you so much, Dr. Rachel Rubin. Thank you.
Thank you for having me.
Yay. Oh, that's awesome. So folks, expect to hear much more from Dr. Rachel as we go forward. And for now, this is Jan James from Hope After Breast Cancer. We'll see you next time. Take care. Bye-bye. Girlfriend, thank you so much for listening to our podcast. I hope you found some nuggets to encourage you and give you hope. Make sure you subscribe to the podcast. You never want to miss an episode. And we'd love to know how we're doing, so please be sure to leave us a review. Until next time, this is Jan James encouraging you to remember there is hope after breast cancer. See you next time.